And so this year is the year of the horse. And so we're supposed to be energetically ready for big movement.
But you really haven't lived until you've seen somebody who has a complete tear of the distal biceps attachment and then doesn't find a surgeon in time.
We're good, but we're not that good.
Scar tissue doesn't come back. So that's, if it comes back, you come back and see me.
Just when you think everything there is to know about frozen shoulder, a different frozen shoulder walks in and it teaches you something new.
Nerve pain's the easiest thing to treat. And he said, what'll I do if it comes back? And I said, for $2,500, it won't come back. Or if it comes back, you don't need to fly and see me. You put the contacts here and the contacts there. You go to that program, you push the button, and it's done. You have control. And it's important.
Thank you for subscribing to the Frequency-Specific Microcurrent podcast. FSM is a breakthrough tool for medical practitioners who feel stuck with limited treatment options, especially for complex issues unresponsive to conventional care. FSM training is the best continuing education course for medical practitioners. Get our free introductory webinar at frequencyspecific.com/about or find FSM trained practitioners at frequencyspecific.com/find. Here's Dr. Carolyn Pittis.
That's what's outside my window as I'm working on the advanced. Oh my God, what is that? I have to pin Kim because right now you're pinned. What have you got on? Happy New Year. Oh, I love it. I just love it.
I told you I would bring my Happy New Year's hat. And I brought Happy New Year's sunglasses instead.
Okay, bye. You told me you were what?
I said I'd wear my Happy New Year's hat when we did our Happy New Year's episode. So this was the best I could find were my Happy New Year's glasses.
Agree. Yes, that's. Did you see the ocean?
I did. And that's why I texted you. Like, amazing.
Yeah.
You sent me the pictures, but just seeing it live like that looked incredible.
I sent you the pictures of the sunny day. Oh, I can take these out. Of the sunny day. And then yesterday I woke up to clouds in the sky and it rained pretty much all day. We had about an inch. And when I went to dinner last night at 5, because it gets dark around 5, the rain was horizontal with the wind coming from the ocean to everywhere east of the ocean. The good news is actually what I've mostly done is enhance the front part. I haven't gotten to the part that I haven't redone yet, but I have till Sunday.
You've got time.
I do. And it's just, this was like the perfect setting.
Good.
Yay.
I'm glad. It's been a big week already, 2026.
In what way for you?
I was speaking with a client who's into the Chinese years of everything. They were explaining that last 2025 was the year of the snake, and there was a lot of latent and stored energy. And so this year is the year of the horse, and so we're supposed to be energetically ready for big movement. And I think it's just very serendipitous that you are at the ocean right now where there is a lot of latent energy and a lot of big movement happening and the ebbs and the flows. But I feel very excited about this year.
And the schedule for 26, that took 3 slides this year.
Yes. And so 2026 is a year of big things. We're introducing the rehab course. We've got some really fun international locations to have the courses.
True.
So it should take up 3 slides because there's a lot going on.
Yeah, there were 2 slides. For the international courses, we're in Poland first, and that's in August and September. And then in October, we're all in Costa Rica. And you have 5 days to do the rehab course after we do a 5-day core. Yep. And anybody that was there last year, is busy trying to recruit their friends to come. It's worth the trip.
Yep.
And then in November, we're doing really for the first time ever, that's another set of slides I'll have to write, is 2-day visceral course for naturopaths.
Yep.
So it takes Dr. Musnick's slides for the visceral are intended for people who are not medically trained. So naturopaths have medical training. So his slides are a little too basic for them. So I can take some of that and but then expand on it and pull some of the material out of the advanced. So the London naturopathic course may turn into its own course in the US, but that's right now it's 2 days. We'll see if we want it to be 3 days once I finish the slides. And then Wednesday through Sunday, I think we do the regular physical medicine core for London, the UK, Ireland, probably Italy, Germany, France. We're not going to go to France this year. And then we're in Poland in August and September. So we're doing a 3-day advanced in Poland, a 5-day core. And the schedule for the 5-day US core is based on what we're doing in Costa Rica. So it's Sunday, Monday, Tuesday, Wednesday off, then Thursday, Friday, and that way they can fly home on Saturday. I was tempted, and Kevin changed my mind, or yes, I was tempted to do Sunday through Saturday and actually take 6 days to do the core, which is what it needs at this point.
Yep.
It's with a day off to integrate and visit the river and to go shopping or get a massage or whatever.
Yeah.
And so if anybody has any feedback about should it end on Friday or Saturday, and do you want to fly home Sunday and then go to work on Monday? Basically, people lose the whole week anyway. So what's the point of starting on Wednesday when you're not going to work one day on Monday and then fly on Tuesday from around the country? The core will start on Sunday and end on Friday unless people vote otherwise, and then we'll end on Saturday.
Yep.
It's either way. So it's
it's a good time to make these big announcements and we're starting the year with the advanced, and the advanced is going to be amazing. And
it's December and we already have, I think the last message I got, we have 200 people signed up. 175 was one email, and then I got a message or an email that said close to 200. So, and we still have 2 more months, 3, 2 more months.
The sports course sold out in record time this year. I think it was mid-December. We ran out of space. So we're going to get a little creative. I have a waiting list that I'd love to let people in on it. So I'm going to hopefully let some people know pretty soon. I think we can just, instead of having tables in that La Ventana room, I'll just put the massage tables strategically, and people end up sitting on the floor and jumping around anyways.
The other possibility is, the other possibility is to get you a larger room.
Yeah.
And Santana is not that hard to work in. You just create the kind of space that you need.
Yeah.
And we can talk later and include the hotel staff and see if you want to
go over Santana instead.
Expand it and move over to Santana if they have it available. Do you want to do that?
Let's do that. I'll make a little note. That's what we're going to do.
Okay. That would be fun. And the dates for London are, hang on, it's here, right in my calendar. London was November. Was going to be October, but we couldn't be in Costa Rica and London at the same time.
We're good, but we're not that good.
Yeah, right now London naturopathic is the 14th, 15th, And the 5-day core is the 18th through the 22nd.
Yep. Kevin's putting it on the chat right now for everybody in case they missed it. Thanks, Kevin.
Yeah. Thank
Happy
you,
New Year,
Kevin.
Kevin.
Happy New Year, Kevin. It's pretty fun.
Yes. So for people who didn't get the introduction or join us a bit late, you are not where you normally are in your office. You
Oh,
are Oceanside finishing the slides for the advanced because it's
yes.
very hard to work from home and it's hard to work in the clinic. I have been going to my neighborhood library actually to write the rehab course because we have a beautiful library and I love books. And there's
Oh,
just something very nostalgic about working in a library. So that's been the birthing place for the FSM rehab course. And you are birthing more slides for the advanced Oceanside.
yeah, it's true. And this is a pet-friendly room, so there's no carpet, so there's no mold. And I'm in Yachats, Yachats, on the Oregon coast, because Neil Nathan lives 2 hours south of me.
Right.
And he and his wife drove up, and we spent Saturday and Sunday together. And then I actually got to work a little bit on Sunday and then a little bit on Sunday, not at all on Saturday, and started on Monday. So here we are.
Neil Nathan's latest book. It is in my little shelf over there.
Toxic.
I'm going to pop it. I'm going to grab it to show everybody. 1 second. I don't know if it's the latest one, but it's a fantastic one. The Sensitive Patients
Oh, right.
Healing Guide. So, top experts offer new insights and treatments for environmental toxins, Lyme disease, and EMFs. Terrifying
Right.
and very informative.
Yes. And
So,
I found out that he has a book that is specific to mold and mycotoxins that is only available on Kindle.
interesting.
And I thought I knew everything Neil had to say on mold and mycotoxins until I started reading that. And
Really?
now, it's like I have Kindle on my phone, but I've never used it. I downloaded a couple of books, and that's even The Resonance Effect is on Kindle. And Neil said this one is only as an ebook. He just put it on.
Yeah.
And he takes this very complex subject and makes it really user-friendly.
Right.
It's really highly recommended.
Okay.
The mold webinar is a good place to start, but yeah, it's really good.
Mold is a very complicated for even the experts out there. There seems to be so many different directions and avenues, and some people want to start in one direction, somebody else wants to start in another. This is when I always text as many people as I can, whether it's Dr. Musnick or Dr. Sosnowski, yourself. Look at Neil Nathan's guides because the spectrum of symptoms are super complex. The treatment routes are super complex. So, for the practitioners that are listening, don't ever think it's something that is a slam dunk that you can handle by yourself.
Well, and even what Neil said was that mold patients, some of them are fairly simple. You
For
take
Neil,
a
do that.
set of, no, for actually, even for me, it's fairly straightforward. You have a set of symptoms, and this is part of what I'm doing in the advanced. It's if people are coming to the advanced looking for recipes or pre-programmed stuff you can put in the CustomCare, not going to happen. There's no algorithm. There just is not. Every
Yeah.
patient is going to be individual. And so with mold, there's a set of symptoms that sort of coalesce and go together that make you start asking questions and at least do a urine mold test. The blood work that Shoemaker recommends for central signaling hormones that are turned down by mold is extremely specialized and really expensive. And the urine mold test is as good and tells you what species and more or less what to do about them. And then you find out how sensitive the patient is and how heavy their exposure is. And you start with binders, and then it takes medication and remediation of the environment if you're still living in mold. And then FSM comes in because we have frequencies for mold, we have frequencies for the vagus, and we have frequencies for inflammation. And one of the big challenges is in mold sick patients is inflammation. And that's when you read the book, it's all right there, how it works, why you have IBS, why you have brain fog, why you can't sleep, why you have digestive problems, why you have sinus infections, why you have bladder pain, why it's all right there. And
Yeah.
and that makes it, once you understand the process, then the treatment becomes more manageable. It's
Right.
just straightforward.
And to piggyback off of what you just inserted, people coming to the advance thinking that they're going to get a recipe. I really hate that. I hate that term. I don't get irritated. It's nobody's fault, but I think the thing I'm most proud of professionally is teaching people to think about conditions in a bit of a different way, not just a biomechanical way. If you have this, you treat it this way. It's, and I can only say this because I've been in practice 25 years, is yes, having a recipe card is perhaps a good way to start, but it is not I believe it wholeheartedly. We are offering a basic, maybe template to follow, but giving people the tools in which to add their own ingredients and their own techniques. And I think that is, and to talk about things, and that is the way successful dishes and recipes, if we're following that example, come into fruition. Because one of my favorite things to get are emails from people who have taken your course, my course, or someone else's course, and saying, I did this, but then I did that and I got this. I'm like, oh, that's so cool. I love the way you thought about that. And I think the sharing to me is what I'm most proud of. I know from a business model, the people that I consult with say that this should be copywritten, this should be proprietary, this should be hidden, this should be secretive. This is, and it doesn't sit well with me, and I know it doesn't sit well with you. And I think
Well,
why we're
aside from anything else, it can't be. I taught it for a year before I even talked to a patent attorney, and found out that you can't patent something you've taught for a year, and you can't patent a medical technique. If you develop a gadget that can be used, so you develop a new way of doing an appendectomy, you can't patent that new way. You have to be willing to teach it to people. But if you can develop a gadget that is specific to make it possible for you to do the technique, then you can patent the gadget. The reason Mary Ellen Chalmers could patent the frequencies for FSM used in dental is it's called the dental exclusion to the patent law. And so there's that. And then I went on a cleaning jihad between Christmas and New Year's, and found a box that was like on the top shelf in the back of the garage, those boxes. This one I didn't even know was there. And I said, oh, and it's in here. And it was the interdisciplinary healthcare symposium that I put on with the med school, the chiropractic college, and the naturopathic college, and the acupuncture school. There used to be 4 medical schools, one from each discipline. And I formed the Interdisciplinary Healthcare Symposium. We did it 91, 92, 93, and in 94, after I graduated, We actually got continuing education credits for it. And I have laminated the front page of the Metro section of the Oregonian because they sent a reporter. And I had written down my vision for an interdisciplinary cooperation between the medical professions. So that was open and free communication and mutual respect and all that stuff. And as I read through what I wrote in 1994, I've discovered that's what we've created with FSM. We have every medical profession that has a license to see patients.
Yeah.
And it's to watch that kind of collaboration. There are some things I can do that can't be done without the 3 people in Portland that I know treat mold.
Right.
So it's pretty exciting.
And one of the things like I said, I'm so grateful for, because if you would have told me 10, 15 years ago, the patients that would be seeking me out to help them on their journey, I would be like, that's very odd. But
Would
now
have believed it.
would have believed it. But patients and clients just teach us so much with everything that they bring in. And just when you think everything there is to know about frozen shoulder, a different frozen shoulder walks in and it teaches you something new. So I am so grateful for that. Speaking of learning, we have some questions.
Yes, we do.
Okay.
Let's see.
Leaf, I'm going to answer his very quickly first. Any thoughts on numbers to enhance bodybuilding? As much as 40 on A, 46 on B can help release sarcomeric fluid, would 81 on A, 46 on B help to pump up? This is in the Sports Advance, Leaf. So I have a few case studies on this very thing. It's more than just turning up or turning down the activity in the sarcomere. As we all know, there needs to be, oops, I just opened that up. There's a lot that goes on with hypertrophy, starting with a synapse going all the way to the muscle belly. So it's too complicated to just say, run this and you will get a bigger pump or you'll get more hypertrophy in the muscle. The biggest thing with bodybuilding, and it's just like with sport, is there is tearing and repairing. And that process is what creates muscle growth, right? We don't gain more muscle fibers. We're not frogs. I think frogs and maybe cats might have they actually grow muscle fibers, but we do not. Our muscle fibers just change size and shape. So recovery actually comes into play a lot more than just what's happening with that pulling apart and that contraction. So 124 actually becomes really important with bodybuilders because they are tearing at a microscopic level and then they are repairing. So if we can get them to train heavy, and that's what creates that hypertrophy, right? It's not lightweight with multiple reps. We're training very heavy with low reps, which those eccentric contractions is what causes the strength gains, but those create a lot of pain the next day. So we get more delayed onset muscle soreness from those types of training modalities. And running 124 in the connective tissue, on the sarcomere, on the fascia, that helps them the next day wake up and feel like they haven't been hit by a truck. So what can they do? They can train harder the next day. So that's why there's a whole day that I talk about this stuff, because it's not just a quick 40-81. Sorry, I'll let you jump in.
There's the number of people that I've treated who really got into weightlifting. The challenge that you have is picking the right, for the athlete anyway, or the person that's training, is picking the right balance between strengthening and tearing the tendon.
Yep.
So those are the ones I see. I was lifting weights, and you really haven't lived until you've seen somebody who has a complete tear of the distal biceps attachment and then doesn't find a surgeon in time, and the surgeon he goes to says, yeah, it's completely retracted, and so that's what it's going to look like. So My preference, based on not treating people that want to bulk up, but people that want to stabilize, is light weights and low reps first. Increase the reps so you strengthen the muscle endurance and build up, if that's possible, the mitochondria and the calcium channels that make the muscles work properly. You do that with increased reps first, multiple sets of increased reps, and then you increase the weights slowly. And that's what I do in a non.
Right. That is the absolute corrective exercise model.
Oh, goody. I got it right.
Yeah,
Yay.
of course. When do you get it wrong? Well,
Yeah.
anyway. So yeah, and there's so many different models. And like I said, in the sports advance, this is talking more on performance enhancement. So this is thinking there's nothing to rehabilitate. Everything's functioning and firing the way that it should. And then to go back to your corrective exercise model, the biggest thing and one of the things I'm most proud of is that afraid to move, right? So when we want something to contract and fire and to stabilize and to be healthy, the nervous system has to believe that this pattern is not only safe, but it's optimal and it's positive. So that's when we get to go back and work with 40 and 89 and all the patterning things, because if there's one thing I firmly believe, and it is proven to me time and time again, is that is the true foundation for rehab, is making sure the nervous system believes that this pattern is safe.
And you have to be, when you go to lift a weight and your nervous system, your cerebellum and your midbrain says, what? No, don't do that. You can run 40 and 89 all you want. And if you are doing something, you're about to lift a weight that's going to tear your biceps or, strain a tendon, you have to listen to that. And you can run 40 and 89 all day. And that neurologic response is a billionth of a second. It's fascia, it conducts at 400 times the nerves. Oh, speaking of which,
700 times. Yes.
700 times. I get to do the fascia dissection class in London in June, where they're going to dissect the vagus nerve. And then I'm got to get Joseph to figure out a way to get me to Cremora, Italy, for the fresh cadaver dissection. Both classes are filled, so don't get like I was the last one that slipped in the door, just it was slammed shut. So that's the high spot of my year, one of the high spots of many high spots of this year.
That's going to be amazing.
Speaking of new things you learned, and speaking of things that I missed,
Yes.
one of the things I did yesterday was order new dermatome charts for the clinic, because I had one old one that had the cutaneous nerves on one leg and the dermatomal nerves on the other leg.
Right.
And I had a patient in the week before Christmas that had sciatica. And it's, well, that's easy, right? So I did 40 and 396 for an hour one day, and the pain in his big toe and his leg got better. And then the next day, his pain was down except for his big toe. I said, I'll just treat it again. So I did 40 and 396 from his leg to his foot. And he came in on Thursday and he said, my big toe still hurts. In my head, there's the little flashing neon sign that says it never doesn't work.
Yeah.
Is there a cutaneous nerve? So I checked the medial side of the big toe and the lateral side of the big toe, and the sensation was different on the two sides. And I have one dermatome chart that says that's all L5. And the dermatome chart in the other room said that one is the superficial peroneal nerve, tibial nerve, and the other is the deep tibial nerve. No. So I went and Googled the anatomy of nerve, and there's a place right next to the tibia where the superficial peroneal nerve, the one that was really nasty on him, comes out from in between the compartments, comes through the fascia, goes across the top of the foot to the medial side of the big toe. I think I'm remembering it right. And I went, it can't be that easy. So I ran one machine from his knee where the tibial nerve splits off from the sciatic to his toe and ran 40 and 396 on that. And he went, oh, that feels good. And then I took another machine and I ran scarring in the nerve and scarring in the fascia and the periosteum, because as I ran my thumb down the fascia right there at the tibia, he said, oh, ow, what's that? And I said, that is why your toe hurts. And so he stripped the scar tissue out of that portion of the nerve and ran 40 and 396 to quiet the inflammation of the nerve, scarring in the nerve, scarring in the fascia, scarring in the periosteum. And then we had to run 40 and 89 because basically the only representation for his big toe was in the thalamus. And then I ran increased secretions in the sensory cortex to reconnect it to the sensory cortex. And then we had to teach him to walk again. But it was done. And I wasted 2 days doing what I always do, which is thinking it's a dermatomal nerve. I had never, ever in 30 years seen the big toe split in half by 2 different cutaneous nerves.
Right.
That's nuts.
Yeah, what I want to do now is just like email everybody that had toe and foot pain to come into my clinic, because now I have to look at 2 parts of the same toe.
And you have the superficial, it's a superficial and deep tibial nerve, and then there's a superficial and deep peroneal nerve that comes along the lateral side and does, it's so not fair.
So I have a couple things to unpack with what you were just saying here. So what you always run multiple machines on patients, correct?
Only because I only have them for 4 days. And so that's what makes it worth what I charge per hour. And why they come long, because I don't have twice a week for 4 to 6 weeks.
And I have similar out-of-state athletes that come in that need multiple machines. And when that comes, I understand the necessity to have all hands on deck and throw as much as you can. Recently, I had somebody reach out to me that went to see a different FSM practitioner, had really good results. The practitioner that they went away to see ran 5 or 6 machines on them following your same model. They now have a CustomCare, but find it they don't have the same benefit with the CustomCare as they did with that practitioner, even though they did very little manual therapy, a lot, but just the benefit of having so many devices. How would you respond to something like that?
I have the same problem for somebody that has both, let's say, spinal cord and central sensitization.
Yeah.
So I'll do one CustomCare protocol that's just 40 and 10, quiet the spinal cord. Another one that's just 40 and 89 or vagal tone. And then one that's the combo.
Yeah.
The other one that you see needs to be done together is 40 and 89, 40 and 10 to quiet the body pain, but 81 and 10 to reduce tone, because the patient has basically muscle pain and tendinopathies because of increased tone for whatever reason. And so I'll do on the CustomCare 40 and 10, 81 and 10, and I just call it tight legs, and the other one is called body pain. And then body and tight combo is the title of the one that's, say, 20 minutes on 40 and 10 and 20 minutes on 81 and 10. And you do that for an hour, 20, 20, 20, and 20. So that's an hour and 20 minutes. And that is one way of doing it. Some of the patient will say, how will I do this at home? And it's, you don't have to do this at home because it's done. Scar tissue doesn't come back. So that's, if it comes back, you come back and see me. It's the maintenance stuff that is concussion in Vegas always goes at the top, but I call it, I think they need to be concussed to use it, and they don't. Then whatever their next biggest challenges, it's going to be back pain, neck pain, facet repair, facet subacute. There's, at this point, there's so many slides now on the working on the psoas. So for a patient that has both discs and facets in the low back, it's never the discs and facets, it's the psoas.
Yeah.
Like it's universal. And a lot of times the multiple machines let you do the manual work, inflammation in the nerve, scarring in the nerve, quieting the cord sensitization, doing all that at one time. And that one I don't know how to do on a car because like nerves really do have to be treated from where the nerve starts to where the nerve ends.
Right.
And if they have cord sensitization, it's because they ignored the nerve pain.
Yeah.
And that means they need to run the vagus more often.
Yeah.
Does that make sense?
Yeah.
Yeah. So I don't even know. Yeah. And like you, it's one precision care and one custom care is minimal for anybody that does.
Yeah. What we do.
Yeah. And any mildly complex patients, and new practitioners usually get a custom care because that's what they can afford first off, after all they spent to get to the course. The smart ones get the precision care and a custom care and figure they're going to be paid off in 3 months. So don't worry about it. And then you start adding.
Yeah.
So in my treatment rooms, I have 3 custom cares and maybe 5 or 6 precision cares.
Yeah.
But if you program the custom cares right, the only reason I use precision cares is that I can set it on a single frequency combination and leave it there for an hour or an hour and a half. And so you can program a custom care to do that kind of job and just program your most common combinations. But figuring things out like this cutaneous nerve in the big toe, who does that?
Yeah.
What?
Yeah. And that was the part where I started. I'm so grateful at all the learning. And I think you could look at it 2 ways. Some people do contact me, practitioners. This is just so frustrating. I just want a recipe card. Just tell me what to run. I'm just going to pull it off the mode bank. But when I do, it doesn't always work. And I'd like to reiterate the mode bank is a really great starting point. Think of that as the recipe cards in your Rolodex or in your cupboard to look at as a template in which to start and delete or add. For instance, people keep asking me about my quote unquote post PRP recipe, and part of it is my own fault for maybe calling that during the sports course. So I'm going to do a better job at not calling it a recipe. And I'm so excited to present with Dr. Reynolds at the Advance, who's going to talk all about BMAC and stem cell and PRP and what actually happens with biologics, because it is a really growing field in sports medicine. And so as the good FSM practitioners that we are, to help support our patients before procedure and after procedure. So things like shoulder repairs, ACL repairs, a lot of the time they are going to be doing some sort of biologic injection at the same time as the repair. So our friend 40 on A, we no longer want to use post-operatively because they're doing stem cell or PRP. And people are freaking out. How can we do something post-operatively without 40? And I'm like, let's think about it for a second. The 40 was such a small piece in the post-operative quote unquote recipe. A lot of it is the bleeding, the anesthetic, the
Torn and broken, the trauma, the
exactly all of those other things. The 40 is just the small little piece of that. So going back to the mode bank, they're like, now what do we do? Go back to your mode bank and just delete those lines. It's really
well,
easy.
you clone it, you copy it, rename it,
Sure.
and then modify it for a particular procedure. It's
Totally.
if for those of you that cook, and back when I used to cook, there is in the recipe book a, a beef stew,
Yep.
and then on a card in a very well-worn 4x5, 4x6 file box is Aunt Arlene's beef stew. And they have a similar pattern,
Yep.
but the quantities are different. Some of the one or two of the she adds what? Oh, I would never have. Let me try that. And so it's the same thing with the CustomCare. It's like you can take subacute facet and modify it. And that's how I came up with facet repair, because it's not chronic, it's not subacute, it's a subacute facet that you want to repair because it's been subacute so many times. And so it's just, there's this one graphic that I've run across in the sports that I'm going to end up copying and pasting at least 7 times, because you have to see things 7 times to remember them. And it has to do with flexibility of mind. So those of us that were pre-med, you had to get A's if you wanted to get into med school. So I got A's just because I'm OCD and I like getting A's. But what I found out is I don't remember anything from organic or bio. It was biochemistry and organic chemistry that scared me. And I don't remember much of anything about organic chemistry. The purpose of taking organic chemistry and biochemistry and making you get an A in it is that in order to get an A, you have to pay attention to detail. With FSM, you pay attention to detail, to causation, and you have to have flexibility of mind. You don't get attached to your first idea. And I broke that rule on day one with this one patient. I was attached to this is sciatica. That's what makes his big toe hurt. And it was the second day and his big toe still hurt. And it was the third day where my mind finally got out of being inflexible. And I went and looked, and it's cutaneous nerves.
Right.
So it's flexibility of mind. So yes, there's a recipe, and when it doesn't work as well as you'd like it to, you add a little more oregano or put a bay leaf in.
Yes. Somebody just wrote something diverse.
Qigong teacher calls a flexible mind a diverse mind. Yeah.
Yes.
And then Annie has a question about real time is still the best lab for mold testing. They've been bought out by, I'm not sure it's US Biotech, but they've been bought out by somebody. And yes, there's testing still stands as the most accurate. Great Plains was pretty awful. And like I did match samples on the same day from the same patient where I knew his exposure and I knew what he had, and real time was correct. and Real Time's the one that Neil likes. But Great Plains has been bought out, and I met the person who owns or runs the company that bought Great Plains, and he says, yeah, we're fixing it. So I haven't done any of their tests to compare, so I don't know. But where's the mold function? Oh, Suzanne, as an LMT, who's the best to refer a client to for mold issues? Functional medicine. Neil and I had that conversation. My challenge with functional medicine since about 2005 was that Jeff Bland raised me from 1995 till about 2005, and he taught critical thinking. It's like, this is the biochemistry, this is the pathway, these are the symptoms that happen when that pathway isn't working right. Now, where do you intervene? And that was how I started in functional medicine. When they had Jeff leave IFM, they threw him off the board. They needed to grow IFM. And so people that are, no offense to the folks who've paid for certification and all that, but the people that I've met who've trained in functional medicine and been certified in the last 15 years, once they started the modules and the deep dives and the coaching and all that stuff, is they really don't seem to be able to make a clinical decision without $2,000 worth of testing from labs that they have all this data that they get from these tests, and they have norms established, but the tests are so esoteric. You wonder, how did you find a normal group? How do you find a normal range when you're testing something that has no norm? And how did you do that? So there's a lot of testing and a lot of supplements and not a lot of critical thinking is what I found. So I tend to search Neil Nathan's website for Neil Nathan MD, or maybe it's Dr. Neil Nathan MD. He has a list of docs that he has trained, or he has a mentorship program, and they're trained in treating mold. And if you can't find somebody near you, Suzanne, that is on Neil's list, you can email their website, I think. Go on their website, ask if there's a practitioner list that isn't listed. And it's like our list. I don't think they charge, but so like our list, we only list practitioners on the website that pay $89 a year because it costs us $20,000 a year to maintain the practitioner list. And so you can find somebody that way. And then actually, other than that, I don't know. Kim, how do you handle it?
Yeah, I usually start with my favorite 5 that and that's another reason why going to the advanced in person is such a game changer, because of the networking that you can do. And it's not a schmoozy networking. So I don't like the term networking, just sounds corporate. The relationships, friendships that I have, genuine friendships that I have because of the advanced. Again, just very grateful to have that platform to be able to grab a coffee or sit next to somebody at lunch, and then that is sprouted into something. So I would say like the functional medicine practitioners are probably the ones that I gravitate towards first, and then they can point me in the right direction.
Especially some of the older ones that were trained before the
Right.
corporatization of functional
Sure.
medicine.
Yeah.
And there are other training places besides IFM, and somebody with some mileage. And sometimes it's just a search of mold specialist near me.
Yeah,
kind
exactly.
of thing.
Yeah.
And leaf, could peripheral neuropathy relate to cutaneous nerves too? No, sorry. Peripheral neuropathy is vascular, and diabetic peripheral neuropathies and chemotherapy peripheral neuropathies have to do with compromised circulation to the peripheral nerves. And something that acts like a peripheral neuropathy but isn't a peripheral neuropathy is a small fiber neuropathy. And we have Ben Catholi's presentation, and that's going to get lifted out of his presentation and put into my advanced slides, because we have on the laminate, we're going to have a frequency for the small fibers and then how you treat them to get them to recover. So
Right.
that's, yeah, the nervous system is complicated.
Yep.
Yeah.
And then did we read the top one? As a patient with a CustomCare, if I
Oh, yeah.
sustain a mild injury, like one that would require a chiropractic adjustment or two, like missing a drop off of a sidewalk, what would be a protocol to use while waiting for the chiropractic appointment? Would it be counterproductive to say use the arthritis protocol?
I'm not sure what the arthritis protocol is, but
So
yeah,
maybe it's not a good idea if there's a 13 or 58, since it's also a new injury.
right.
Yes and yeah, oops, yes and no. I just put it,
Oops.
I just closed it by accident. Sorry.
Okay. Yep, no, gone. When I, and this is, I guess, a conversation we should have with practitioners, when I program a CustomCare, there's the patient's top 8 things that they need treated. Their problem list is 8, maybe 10.
Yeah.
And then after that is FSM first aid. There's acute soft tissue. There's skin wound healing. There's subacute or soft tissue week 1 to week 4. There's shingles. There's fracture for anybody that has a male child or any right in the household. There's skin anti-aging. There's breast health. There's heart health. There's vagal tone. Concussion in vagus is always the first one. Brain fog, tendonitis, partial thickness tendon tear, shoulder pain, knee pain, back pain, neck pain. Back pain and neck pain treat both discs and facets, ligamentous injury, ankle sprain. So you've got room for 45. I've never put that many on somebody's unit. Common cold. And if common cold doesn't work after 2 days, you're on COVID. And what else? Insulin resistance, insulin and leptin resistance. What else do you put on for first aid? Oh, delayed onset muscle soreness, especially
Yeah.
if the patient
Like
is,
soft tissue acute. Yeah.
yeah. But delayed onset muscle soreness, just 20 minutes right after you work out, especially for dealing with a patient that has been unable to exercise for 4 or 5 years.
Mhm.
And now it's, oh, goody, I can go back to the gym. It's put delayed onset muscle soreness on.
Yeah.
Yeah. What else would you put on for first aid? What did I forget?
I don't know. I think you covered, we have concussion in Vegas on there, right?
I've got one that's just stop bleeding on my personal CustomCare. Just
Yeah. Yeah.
prevent bruising.
Yeah, like I have a lot of 124s and something like a lot of those one-liners.
But you have to call it something when you're putting it on a patient's unit.
Yes.
So
So I'll say like repair,
new fracture. Yeah.
CT repair, like connective tissue repair, fascia repair, bone heal, something like that. Yeah, the new fracture protocol is great. I won't call it new fracture. I'll just call it like,
Acute fracture.
yeah, or like
Yeah.
for, I don't know, yeah, bone pain or new bone pain, something like that, depending on who it's for, because the word fracture can freak people out. And even if you whack your shin, the acute fracture and new fracture protocol is fantastic for that.
Because what you have is bone bruise.
Exactly.
Yeah.
Yeah,
It's fun.
that
It's
it is.
it's empowering to the patient. Some practitioners are afraid to seem commercial if they try to sell or encourage the patient to buy a CustomCare.
Yeah.
And in the pain management world and in my world, I see patients who have been in 5 or 6 car accidents, have body pain, back pain, low back pain, knee, whatever, and all of their care in the last 20 years since the first accident has been passive.
Right.
I get massage and I see a chiropractor and I go to acupuncture, and it lasts about a week or a day or whatever. And it's, have you done any active care? Oh, I went to physical therapy, but it made me worse. And it's okay. So we're going to give you some exercises. And I demonstrate those most of the time in the core, if I remember. And this little unit that I used on you here in the office gives you control over your back pain, your neck pain. And the pain literature is really clear that giving the patient a locus of control over their own pain. This guy should never have been in nerve pain for 5 years. Insane.
Yeah.
Ruined his really, he did not have a life for 4 or 5 years, and messes with your brain, messes with your hormones, messes with your digestion, messes with the whole rest of your body. And nerve pain's the easiest thing we treat.
Yeah.
And he said, what do I do if it comes back? And I said, for $2,500, it won't come back. Or if it comes back, you don't need to fly and see me. You put the contacts here and the contacts there. You go to that program, you push the button, and it's done. You have control. And it's important.
Yeah.
So there's actually there's a new section in the beginning part of the advanced, and that is how to deal with patients' emotions as the emotional states, like the stages of grief, patients' emotional states as they recover.
Yeah, as they heal. There's so much that I remember my first, and I know we're almost out of time, but it was somebody who was in a pretty bad car accident 3 years ago, was really plateauing with other practitioners as far as pain relief and mobility, and saw me, and the brain fog was gone, the neck mobility. Like, it was just the concussion protocol plus supine cervical. And after 3 treatments, everything was better. And then came in on the 4th treatment, mad,
Furious,
furious, and I was
angry.
super angry. And I was like, what? And it was, I lost so much time. Why didn't anybody figure? It was this whole host of things that he was angry at. And it really threw me for a loop.
Yeah. And it is really, I know we're almost out of time, but it's really standard.
Right.
They experience relief. Oh, thank God, I'm better. And then it can be in as little time as 24 hours.
Right.
They are pissed
Yeah.
at, I told him it wasn't in my head. Why didn't he order those x-rays? Why?
Yeah.
And then there's grief over
Yeah.
what they lost.
Right.
And then there's, now who am I? There's a
Right.
certain amount of fear,
Yeah.
uncertainty. Now what do I do? I've
Right.
been on disability for 5 years.
Yeah.
What do I do now? And you don't have to get off disability unless you want to.
Right.
That's all right.
Yeah.
If you recondition and if you find something you want to do, you can do that.
Yeah.
And then actually there's now a section on hypnosis, what kind of language to use. Oh, Maria, no, we're not coming to Australia. Then
But I am talking to people, so I will be coming at some point.
Oh, good. This year, 26?
We're working on it.
It's like we're going to India in 27,
Oh.
and I might be able to go back to Australia in 27. It's 27, I'll be 80, and it's what the hell. So that'll be fun.
Yeah.
Yeah.
Yeah,
So
that's it. It's
4 o'clock already. How'd that happen? The usual way, right?
you, me, and the vortex of time.
True story.
You enjoy the rest of your days by the ocean, creating all the brilliant slides that you're going to grace us with at the Advanced in March. Sign up for it. Come in person. Come have lunch with us. Join us live stream if you must, but it's going to be great.
Yeah. And uh, not to gild the lily, but the food. So there's a waiter there his name is actually Prince. And he knows that I like strawberries and whipped cream. And he finds me wherever I'm sitting eating tacos or whatever. And he brings me a little plate of strawberries and whipped cream. And so we don't serve nasty food. We serve fresh fruit, fresh salads, fresh. If you just came for the food, I guess it would be worthwhile, wouldn't it?
Yes,
Just
100%.
Yeah.
The food and the friendship.
Friendship. It's the one place in the year where you are with every single medical discipline, and there's a FSM hive mind that happens. And it's the one place where you feel normal when you say it was just nerve pain and she just had a little disc bulge. It was not surgical. Babinski was normal. I just treated 40 and 396 and 124 and 710 and supine cervical, and it was done. And yeah.
And lightning doesn't strike you when you say that.
No. And it was really not that hard. She just had Ehlers-Danlos and hypermobility syndrome, and it's all like that. So
yeah, Kevin, FSM, food and friendship. You're so funny. You read my mind. I was going to say frequency, food and friendship. The triple F trifecta of
yes.
Yes.
Hey, that could be a logo. F. Cute.
Yeah.
There we go.
Here it is.
Okay.
See if we get great things done. All right. Keep doing great things out there, and we'll see you next week. Bye, everybody.
See you next week. Bye.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of